I thought we'd begin today by considering the following overarching idea. What does it mean to say that one thing is the cause of another thing? And it turns out this is a very old question, of course. And here's what Aristotle had to say. Aristotle said that there are four kinds of causes, four ways that we can say that A is the cause of B. He said that there's something called the material cause, which is that out of which a thing comes to be. So, for example, bronze is used to make an object. So that would be the material cause of a sculpture, would be bronze. Or there could be something known as the formal cause, which is the statement of essence, or the account of what it is to be. Or, he said, the efficient cause, or which is the primary source of a change. E.g., for example, a man who gives advice, or the parent of a child, for example, might be the efficient cause. Or finally, he said there could be something known as the final cause, and that is the end, that for the sake of which the thing is done. For example, health is the cause of exercise. That's why we might exercise. In one of the most classic examples of understanding what these Aristotelian causes are, Aristotle said, wood is what the table is made of. That's the material cause. Having four legs and a flat top is what it is to be a table. A carpenter is what produces a table. And eating on and writing on is what a table is for. So we can think of the causes of death, as we've been discussing in this course, in terms of whether they are the formal causes, the disease itself, or the efficient causes, let's say the risk factors. So we can begin to reframe the causes of death that we've been discussing so far in this term. And on the left is the usual sorts of lists that we've seen repeatedly in this term of the top, leading causes of death in our society. But I use 2002 as the benchmark year in this slide because I want to compare them to a list, I think, taken from your readings in order to be comparable of a different way of seeing the causes of death. So on the left, we have, diseases of the heart, malignant neoplasm, stroke, and so on. These are the top 10 killers. But on the right, we can think of the causes of death in a different way. Tobacco, diet and activity, alcohol, microbial agents, toxic agents, medical error, firearms, sexual behavior, vehicle accidents, illicit drugs, and so on. And in fact, these risks on the right account for over 1,200,000 deaths, roughly, again, in 2002, which was 50% of the total deaths in our society. And these estimates that are here, which again I think are taken from your reading, these causes can be seen as having additive or synergistic effects. So, for example, being obese and alcoholic is multiplicatively worse than any one of those particular causes. And these exposures actually have multifarious ways of killing us. Tobacco, as I'm sure you all know, causes lung cancer, but it also causes head and neck cancer or esophageal cancer because some of the tobacco smoke, we swallow it and goes down into our esophagus, or bladder cancer because the toxins go into our bloodstream and then are concentrated in our bladder. So smoking causes bladder cancer. And it also causes coronary artery disease and chronic obstructive pulmonary disease and pneumonia. So I need whoever's talking to mute themselves, please. And tobacco causes premature births and neonatal deaths and burns. It kills people by setting houses on fire. In fact, 3,000 people die every year in the United States from inhaling the smoke that other people exhale. And it's a similar story with diet and exercise. Suboptimal levels cause cardiovascular disease, or colon or breast cancer, or diabetes. Each of those causes on the right has multifarious ways of killing us. And toxic agents include occupational exposures, environmental pollutants, food contamination, and exposure to commercial products. And this cause is likely to rise due to global warming and environmental degradation. And in fact, with the opioid epidemic, the count for illicit drugs has increased hugely. So in 2002, we had 25,000 deaths a year from illicit drugs. I think we have 4 times that count now, 20 years later. So changing how we see the causes of death can affect public policy. We spend $900 billion a year on healthcare every year, but less than 5% of that is spent on prevention, is spent on addressing the causes of death as seen on the right rather than as seen on the left. So we spend all this money, dealing with the causes like when we have the perception on the left and not so much on the perception on the right. And today we're going to be discussing obesity and exercise and diet. And next time we'll take up smoking and alcohol and firearms. Well, let's get a handle on what various body mass indices look like, or BMIs. BMI is your weight in kilograms divided by your height in meters squared. And so this shows for a woman that's 5'6", from left to right, more obese to less obese, what weight gives you different BMIs. So if you're 5'6" and 248 pounds, your BMI is 40. If you're 186 pounds, your BMI is 30, and that's the cutoff for being obese. If your BMI is, if your weight is 155 and you're 5'6" and you're a woman, your BMI is above 25, that's overweight. Then the more normal weights, according to medical standards, shown on the far right. And here's what it's like for the guys. If you're a 6'1" man, these are the weights that get you at different BMI thresholds. So if you're 6'1" and you have a weight above 189 pounds, on average, you're considered overweight. Your BMI is above 25. So overweight is 25 or higher. Obese is 30 or higher. Now, of course, it varies. If you have a very athletic build or more muscular, there are other ways of assessing body build and obesity, but this is the standard, simplest way. Your weight divided by your height in meters squared. And this side shows the percentage of people who are obese, who have a BMI above 30, by sex and race and by time period. So, for example, if you start at the top, back in 1971 and 1973, 13.9% of white women were obese and 11.9% of white men, and Black women, 28.5% were obese. So double the rate of white women, 40 years ago, and Black men, 14.9. And if you look across time with subsequent national surveys in these data, coming all the way forward to 2002, which is the benchmark year we're using in today's talk, you can see a rise in all demographic subgroups in the rate of obesity and very high fractions. In 2002, 47.7% of Black women were obese. And by now, in 2020, over half, maybe as much as 60% of African-American women are obese. And there's variation, of course, by gender and race and ethnicity and time period. And men are less likely to be obese than women, and whites are less likely to be obese than Blacks and than Mexicans. And obesity in all groups has been increasing across time, in fact, more than doubling since 1970. Indeed, if you take into account overweight and not just obesity, well over 2/3 of American adults are now obese and overweight. It's really a public health crisis. It's a serious epidemic. And this slide reports the same numbers by average BMI. In 2000, the average BMI in Black women was already 31. So if you look at the bottom there, and so on for the other groups. And by 2017, here's the number I wanted a moment ago. By 2017, 82% of Black women were overweight or obese, compared with 63% of white women and 77% of Hispanic women. So the great majority in all groups is now overweight or obese in the United States. But similar to what we discussed a few lectures ago, the population distribution of weight keeps shifting to the right across the whole distribution. It's like the secular shift in blood pressure we saw a few lectures ago. So it's not just that a subgroup in the far upper right tail of the distribution is getting heavier and heavier. Everyone across the whole spectrum, from light to heavy, everyone is getting heavier. So this slide shows the bell-shaped curves are for different years, and you can see that, and the vertical lines indicate when you cross the threshold of being overweight at 25, or obese at 30, or really morbidly obese at a BMI of 40. And you can see that the peak of the curve keeps shifting to the right with each subsequent decade. And it's not our genes per se that's doing this, obviously, because our genes have not changed over this time interval. Something else is going on in our society that is contributing to this massive increase in obesity in our society. People are getting so big that hospitals are having to make all kinds of adjustments. Special chairs and hoists and special CT scanners and gurneys are needed in order just to move patients. These two nurses on the left are sitting in a chair intended for one overweight, very obese person. Even the drug doses need to be adjusted and rethought. When I was in medical school, we were taught standardized drug doses for different sorts of conditions. You know, if the patient has this, you give them this many milligrams of this drug and so on. But if the person is twice the size, that drug dose is not right. Even the needles, over my training, when I first started training as a doctor, you know, standard needle size was like this long when you were trying to give an injection to a patient, an intramuscular injection. Now it has to be this long because you have to get through this layer of fat in order. So the needle size in hospitals is changing just to get through people's fatty layers. In fact, there are thousands of workplace injuries among hospital workers every year just from moving overweight patients. Now, I'd like to spend a little time exploring some of the individual level and population level correlates of obesity beyond gender and race and ethnicity that I already gave you a kind of a little bit of a feel for just now. The x-axis in this slide is the poverty income ratio, which is a standardized measure of income, with poor being on the far left and rich being on the far right. And the y-axis is the body mass index. And this slide shows, once again, across time, different cross sections of the American public, you know, roughly every 10 or 15 years, starting from 1971 going to 2002, what has been the relationship between income and weight. And you can see back in 1971 and 76, at the bottom of those bottom two curves, the first and second cohorts, the purple and the blue line, that which overlap, that first of all, there was not much change between in that 5-year period because the curves overlap. But second, that there is a negative relationship between BMI and wealth. The richer you are, the thinner you are. Okay, so there's a downward sloping line from left to right. But then you can see that across time, that relationship still holds. It's always downward sloping, but the set point keeps moving up. So everyone, rich or poor, is getting heavier with time, but always there's a relationship between richer people are thinner than poorer people. This slide shows just the relationship in white women. And a big leap appears to have occurred during the 1980s. And this is another way to appreciate that we are in the midst of an epidemic that's affecting all sectors of our society, men and women, black and white, rich and poor. Everyone is getting heavier across all parts of the distribution, across multiple axes. Now, for men, the curves are flatter, if not flat. So with every passing year, men are getting heavier, but the relationship between income and obesity amongst men is flatter. There's less of a relationship where rich men are not necessarily thinner than poor men. Maybe a little bit, but not so much. Now, how might wealth and weight be related? As usual, and I just like everyone to turn on their videos if they don't mind. I can only see some of you, so yeah, it's just more engaged. I wish I were there in class with you today, but I just can't walk, so I'll have to see you next week. As usual, the relationship can go one way, both ways, or some third way, or all of these. For example, income might cause weight status. If you have more money, you might have a better diet, or more leisure time, or places to exercise, or a sense of self-efficacy. You might feel more powerful and able to control your destiny. Or there could be variations in aesthetic norms and expectations. Maybe different socioeconomic classes have different standards for what an appropriate weight is. Maybe rich people sort of expect to be thinner and want each other to be thinner. Or it could go from the other direction. Weight status could affect income. For example, it could affect your labor and marriage market performance. Maybe heavier people are discriminated against, aren't paid as much, or maybe they can't engage in a kind of workforce participation that yields higher rate of return on their efforts. Or there could be some common factor that causes both income and weight status. And these common factors might include things like personality traits or genetic traits. Maybe there's a common gene that causes both how rich you are and how thin you are, just like we discussed the last time. Or, as is probably usually the case with most of these phenomena, all three of these are happening at the same time to some greater or lesser extent. Now, here is some suggestive evidence that the relationship can indeed go from body mass index to income. This data shows the effect of overweight in adolescence on subsequent socioeconomic characteristics among men. And these data are from a nationally representative sample of 10,039 randomly selected young people who were between 16 and 24 in 1981, and follow-up data was obtained in 1988, 7 years later. And the characteristics of the subjects who had been overweight in 1981 were also compared with those for young people who had asthma or musculoskeletal abnormalities or other chronic health conditions. So how did being overweight affect you? And was it worse, let's say, than these other conditions? And men who had been overweight were less likely to be married. For example, they were 11% less likely to be married compared to men who had normal weight 7 years later. And they also earned less. They earned about $2,876 less. And they were less likely to have completed college. All of these, and they had slightly lower self-esteem. So all of these axes of sort of socioeconomic performance were worse among people who had been obese much earlier in time compared to non-obese individuals or compared to individuals with other health problems in adolescence. But I should say there was no effect, no statistical effect in the study in the 1980s on self-esteem. So actually, back in the 1980s, there was no evidence that being overweight affected your self-esteem. And I think the self-esteem finding is interesting because overweight men tend to tolerate their weight. So remember that this data were for men, and so overweight men were less likely to be married, earned less money, completed less education, yes, but didn't have less self-esteem, statistically speaking. The p-value was 0.17, as you can see down at the bottom there, so it wasn't significant. Because overweight men, at least in that data set, tended to tolerate their weight. And in fact, there's a notable lack of correspondence between self-assessed and objective weight status in men and women alike. So this slide shows the lack of correspondence between subjective, what people think of themselves, and objective, what the objective standard is of their weight status. On the columns is whether they thought they were overweight, just right, or underweight. And in the rows was the medical standard, were they overweight, normal, or underweight? And the diagonal captures people whose self-assessment corresponded with their medical assessment. And the off diagonal are the discordant elements. So there are 5,391 people who are overweight, but thought they were just right. In fact, there were 120 people who were overweight and thought they were underweight. And there were 4,408 people who were normal, but thought they were overweight, and 50 people who were normal, but thought they were overweight. About 24%, or 4,458 out of 18,636 of those, if you look at the bottom, 18,636 people thought they were overweight, but a total of 4,458, or 24% of those who think they are overweight, are not overweight. And if you look at the row, on the top there are 16,689 people in the sample. A total of 5,511 of them, or 33% of those who are overweight, think they are not. And the discordance of self-evaluation with respect to medical standards was not homogeneously distributed. Compared to men, women are almost 5 times more likely to overassess their body size. So now if we go in and we look at subparts of the data, who is in which of these off-diagonal elements, women are 5 times more likely to think they are fatter than they are. And those that are young, white, wealthier, or more educated are more likely to overassess their weight status. Norms regarding acceptable body types are socially patterned. That is, it's not just weight that varies by socioeconomic status, but ideas about weight also vary by socioeconomic status. You see, body size is socially constructed too, as you saw in your readings for today. But it's clear that being overweight or obese increases your risk of death. There's a lot of conversation about how, well, maybe it's not so bad to be obese. It's just a different type of body. That's not true. It is absolutely the case that being overweight or obese harms your health in numerous ways. It's definitely a public health epidemic and a public health problem, but it's also an individual level problem. This slide shows the years of life gained by being active compared to being sedentary. And in men, and it's the added life from an active lifestyle in men up to age 80, looking at a sample of Harvard alumni from 1862 to 1978. And then on the far left is how old they are at entry. And then on the first columns, compare people who have a lot of activity to people who have very little activity. And those in the highest level of exercise live 2.15 years longer than those in the lowest level. So across all age groups, at the bottom there, if you look between 35 and 79, at the adjusted years of life gained by being in the most active group compared to being the least active group, you live about 2.15 years longer. Stated another way, these data show the harms of not exercising. And in the study, and I can't remember if I assigned this for you to read or not, in the study, they found that climbing less than 20 flights of stairs per week, or 3 flights of stairs a day, if you climb less than 3 flights of stairs a day, this was associated with a 23% increase in your risk of death. Now, this led to some interesting exchanges of letters by other observers in the New England Journal after this paper was studied. And the critics noted that if you climb 3 flights of stairs per day, that takes about 60 seconds to climb the 3 flights of stairs, and that it lengthened your life by about 3 months. And then they did the calculation and they found that actually the extra 3 months that you lived was just spent climbing stairs. If you looked at the 60 seconds per day and you add it up over a life course. So maybe it was not worth it. But this then leads to a different philosophy. Well, first of all, in addition to living longer, you could be fitter and you might have more quality adjusted life years. You might enjoy the life that you have more, going back to a point I made a few lectures ago about quality adjusted life years. But it leads to another very subtle issue which we alluded to a few lectures ago and we'll return to later in the course, which is, let's say I asked you guys, you're all in your early 20s, and let's say you were slated to die when you were 80. Let's say if I asked you, I could put you in a coma for 10 years and you'd have no life experience right now for 10 years, but your body would be frozen in its current state. And then I would wake you up in 10 years. You would still have a 20-year-old body, but now you would live to be 90. Does everyone understand the hypothetical? So the total, you still live 80 active years with the same body you otherwise would have had, but now you live to be 90. How many of you would make that choice? Raise your hands, like electrically or literally. How many would like to live to be 90, but you sleep for 10 years now? Anyone? I can't see Dorothy. Does anyone take this side of the bet? One person?
Maybe people can also just click the reactions and there's raising hand.
Because when I'm lecturing you guys, I can't see, I only see like 5 or 6 faces. I don't see everyone, but Dorothy sees everyone. Okay, so a couple of people would take it. Okay, Matthew, why would you take it? What would be, in your judgment, the benefit of this?
For me, longevity is something that I think about a lot, and I value every day that I could be alive, and I think that there's a lot of benefit in being able to live longer, and there's no price I could put on 10 extra years of my life. So
yeah, but you spend those 10 years in a coma, remember? In my hypothetical.
Oh, I understood it as you live an additional 10 years after the coma.
No, what happens is right now I put you in a coma for 10 years. You would have died at 80. I put you in a coma for 10 years and now you live to be 90. Would you take that choice or would you live your current life?
Oh, then I wouldn't, because I'd lose time with living family members.
All right, very good point. But what would you gain?
More time in the future?
Yes. So that's, I don't know if advice was about to say that or not, but living longer has this benefit of exposing you to things that are happening in the far future in time. And many people value that. So you might value, even in the hypothetical I said, you live 3 months longer, but you spend it climbing stairs. But you might, in addition to the quality adjusted life years being better because you're fitter, you might live longer into the future and get to see human beings landing on Mars or something. Or you might have some experience that was valuable to you. And we'll return to this point. Now, other work suggests that there's some subtlety here in terms of whether being overweight and obesity per se raise the risk of death. And it does depend on whether you are merely overweight or properly obese. And if obese, how obese you are, and also what cause of death we're speaking of, and how old you are. For example, as shown on this slide, obesity appears to raise the risk of death primarily through its effect on cardiovascular disease. And the risk may only rise substantially when your BMI is above 30. Obesity has a less discernible, if any, effect on all cancers combined. So the bottom rows show all cancers and how being obese affects, or thin, whatever your BMI is. You could have too low a BMI, how it affects your cancer risk, and for 25 to 59-year-olds and 60 to 69-year-olds. In most of those, the lines don't cross 0, so there's no excess risk. But at the top for cardiovascular disease, especially for those that are obese, especially if your BMI is over 30, there does appear to be a risk. Still, obesity, even if it does not kill you, is very bad for your health in other ways short of death, such as its effects on disability, which I alluded to a moment ago. Now, obesity is not just an individual problem, but a public health problem as well. At the population level, a BMI of 30 results in the loss of about 3 months of life expectancy at birth, and a BMI of 35 in the loss of a year of life expectancy at birth in the American population in the year 2000. So the fact that we as a nation are getting heavier is countermanding all these other fantastic benefits we get from more advances in medicine, from being a richer society. So we would be living even longer as a society if we weren't getting heavier. And this public health aspect of obesity in turn raises our usual concern about how to understand the problem from a collective or individual perspective in terms of structure or agency or both. And it turns out that there are numerous environmental factors that are important in contributing to the obesity epidemic. There has been a change in social norms about what a good body size or what a healthy body size is, a kind of tipping point. There's been a transition to sedentary service sector economy. Fewer people are working in jobs that require physical activity. We have more and more labor-saving devices. We have sedentary entertainment options. People play video games instead of being out on the sports field. We rely on motorized transportation. We don't walk as much. We have suburbanization and sprawl. We have cheaper food, and as the price of food comes down, people buy more of it. We have increases in portion sizes, food advertising, and fast food. We have other social changes, such as working mothers. So women are less likely to be at home, and so they're spending, in the traditional family organization, someone was at home, typically a woman, but it doesn't need to be the woman, paying attention to what the family was eating. We have a decline in smoking, which is great, but smoking used to keep people thinner. So the decline in smoking is contributing to the obesity epidemic. And we also may have a change in the microbiome, the bacteria in our guts that may be related to the food content. So the food we eat changes the bacteria that naturally would be within our body, and changes in antibiotic use, because we prescribe more and more antibiotics that kills certain bacteria in our body. And that change in the microbiome at the population level is contributing to our obesity. Yes, Dorothy.
Okay, so I'm just gonna say, if anyone wants to ask questions, you can digitally raise your hand, because in this way the professor can notice it. And also there's a question in the chat section by
So someone
Matthew.
just raise their hand.
Matthew,
Ask
do you
it.
want to ask it, or do you want me to?
Yeah, I can't monitor the chat.
Okay.
Hi,
Thank you.
I'm the one who put the question. The question is, can obesity be classified as a lifestyle issue? And if you had to estimate what percentage of cases of obesity could be reversed via healthy behavior change?
Well, all of obesity could be reversed by a healthy behavior change, but of course, people find it nearly impossible to engage in behavior change. It's very difficult. Well, most people who lose weight wind up gaining it again. And I didn't understand your question about lifestyle. What do you mean? Like it's just a choice that people make, and you can just choose?
So, as I understand it, obesity has now been classified as a metabolic issue, and it's a disease, and the underlying causes are a combination of genetic issues, plus behavioral issues, and the underlying causes, whether it's purely lifestyle related, as in behaviors, engaging in exercise, healthy diets, and stuff like that. There's debate as to what are the underlying causes, and so I wanted your take on that.
Well, the causes, some of the population level causes are listed here. I'm not so interested in a terminologic debate about whether to call it a disease or not, or a lifestyle choice or not. It is obesity, and it's bad for you. I mean, the evidence about its health effects are overwhelming, and I've shown you some of the evidence. There's a vast literature on this, but it's also clear, and it's different genes put you at different risks for being obese. That's true, but it's that propensity to be obese is abetted by the environment. So our genes haven't changed in the last 30 years, but we've all gotten heavier across all groups, partly for the reasons shown on this slide. Anyway, we'll discuss genetic risks a little later in the course. And I don't know if I'm not prepared to say obesity is a disease, but it's certainly a concern for doctors. Maybe I would say it's a disease. I don't know. But that's not the important issue right now, in my view. Some hint of the role of both social norms and environmental factors can be seen by the geographic patterning of the obesity epidemic. So this slide shows for men and women in 1990 and 2000, the fraction of people in different states that are properly obese. And you can see that it's geographically patterned. Some states are thinner than other states. And this is a hint that it might have something to do with social norms in that state, about activity, for example. Maybe in Colorado, they're very active, for example. And something to do as well with the social interactions or the social norms. And indeed, note Mississippi. it had first in the nation status in terms of obesity. And in some rural counties in Mississippi, in this old study, had an obesity prevalence in adults close to 40%. It would be even higher now. So everyone around you is extremely heavy, and that changes your expectations about what an acceptable body size is. And norms are indeed changing. In fact, in 1985, 55% of US adults said they found overweight people less attractive than others in 1985. But in 2005, 20 years later, only 24% of adults said so. So people's attitudes towards body size is changing. Yes, Lucy.
Maybe this is something that is happening in addition to social norms, but I also just know that a lot of these places where there's really high percentages of people with obesity are places where they're food deserts. There's not a lot of grocery stores. And so it would seem to me that that would be a more, I guess, salient effect of this, or maybe salient cause of this geographic patterning than social norms.
No, I think you're absolutely right to raise the food desert topic. All of the foregoing factors are factors. These are all factors. Social norms is one of a list of 10 here, okay? So we're looking at what evidence do we have for each of these factors. The food desert one is complicated, and careful econometric studies that have been done generally show that it's that the people want the bad food and will go to buy it, not that the bad food is located in a place. Like, for example, there was a study that showed that grocery stores that open up and start selling fresh produce in these communities that are very obese, nobody buys it. And so it's not the lack of access to the food that's the problem. It's more of an agency issue in that situation than a structure issue. But that doesn't mean these other structural factors aren't important. The suburbanization, the cheaper food, the portion sizes, which I'll get to some of these. So along with the increasing numbers of people who are obese, there are normative changes too in how we see obesity and in how we define it. Lucy, you can keep your videos on. I generally want everyone's video on if you don't mind. For instance, we are redefining dress sizes as people get bigger. So this is the waist measurements for standard women's clothing from 1958 to 2000. And this is your waist in inches on the left, and what was a size 20 in 58, 70, 2001, and 2011, and what was a size 8. And you can see that we're redefining dress sizes as people get bigger. Culture can construct what a normal appearance can be. And social norms are changing to the point where there is an action-oriented organization, the National Association to Advance Fat Acceptance, that frames its claims in terms of civil rights. For example, here are some photos that you can see from clicking on the URL for the 2005 NAFA convention. And if you can't read this text, but I'm going to read it to you, what it says in the prose on this website. It says, founded in 1969, the National Association to Advance Fat Acceptance is a nonprofit, all-volunteer civil rights organization dedicated to protecting the rights and improving the quality of life for fat people. NAFA works to eliminate discrimination based on body size and provide fat people with the tools for self-empowerment through advocacy, public education, and support. And then it says, why should I support NAFA? And then it answers, fat people are discriminated against in all aspects of daily life, from employment to education to access to public accommodations, and even access to adequate health care. This discrimination occurs despite evidence that 95 to 90% of diets fail over 5 years, going back to Matthew's point, and 65 million Americans back then, now it's much higher, are labeled obese. Our thin, obsessed society firmly believes that fat people are at fault for their size, and it is politically correct to stigmatize and ridicule them. Fat discrimination is one of the last publicly accepted discriminatory practices. Fat people have rights and they need to be upheld. And then it goes on to articulate a vision of a society in which people of every size are accepted with dignity and equality in all aspects of life. Now, this is a complicated phenomenon, isn't it? because we're strongly opposed to discrimination and hatred and victim blaming on the one hand, and should always be mindful of our common humanity. I need to repeat this. We should be, I think, strongly opposed to discrimination and hatred and victim blaming, and should always be mindful of our common humanity. When you become a doctor, you don't judge your patients. You never judge them. You don't judge people who are overweight. You don't judge people who have political views you disagree with. You don't judge people who may have injured themselves by attempting suicide. Your job as a doctor is to care for the patient in all their suffering humanity, not to judge them. On the other hand, this change in social norms, illustrated, for example, by the stuff I've been showing you and the pictures on this slide, is harmful to individuals and to public health. How can it be a good thing to glorify this state of affairs? It's very confusing, isn't it? And going back to what Lucy said earlier, there are a host of structural factors that may render our environment obesogenic. Some have contended that the plentiful supply of excess calories produced by the food industry, in part because of encouraging government policies and agricultural subsidies, is partly to blame for the problem. These cheap calories are dumped on the market, and these calories have to be eaten by someone. This is a slide taken from Marion Nestle's work. She wrote a very compelling book called Food Politics, if you're interested in this. And on the left, she shows federal subsidies for food production. In other words, how much money does the federal government give to make it easier for people to produce calories from meat and dairy and grains and sugar and oil versus nuts and legumes and vegetables and fruits at the top on the left. And on the right are the nutrition recommendations, which are exactly the reverse, right? We, as a government, we have a policy that incentivizes the production of cheap foods precisely for the least healthy things in our diet. And in fact, there's a provocative correlational evidence regarding this hypothesis that as we make it easier to produce corn and sugar, we get high fructose corn syrup, which is put in all kinds of products. You know, if you just look at anything you buy, even things that you think should have no business having that much sugar, because the sugar is so cheap and because people like sweet things, it's dumped into those products. And highlighted in purple is the high fructose corn syrup that's going up, and highlighted in yellow is the obesity rate. And you see a kind of inflection in the obesity rate right around the time that you see an inflection in the dumping or the production of high fructose corn syrup in our society. And these types of effects are not trivial. Even a slight increase or decrease in average calorie intake can have huge population level effects. This slide shows the current rate of excess energy stored by 20 to 40-year-olds in the United States. So it's a distribution of the excess energy that you consume, that people consume, and the proportion of people doing so. So the median 20 to 40-year-old is getting an extra 15 kilocalories. That corresponds to your conventional notion of calories. The average person is eating 15 calories per day. And at the top of the 90th percent of the distribution, 10% of Americans are eating 50 calories more per day. So this figure shows the median of the distribution of estimated energy accumulation that accounts for the observed weight gain of about 2 pounds per year in Americans 20 to 40 years old. In other words, this means that an intervention that reduced energy intake by 50 calories a day, which corresponds to a reduction in food intake of half a candy bar, could offset the weight gain in about 90% of the population. If we could just persuade Americans to eat half a candy bar less per day, we would efface 90% of Americans would no longer be obese. In short, the obesity epidemic arises from the consumption of less than half a candy bar of extra per day per person. And portion size is also a problem. This shows, for example, the size of a Burger King hamburger in 1954 was 2.8 ounces and had 200 calories. And in 2004 was 4.3 ounces and had 310 calories. A McDonald's fries was 210 calories or 2.4 ounces in 55 is now 3 times bigger in 2004. Or look at what happened to Hershey bars. They've gone up by a factor of 3 in 100 years. Or a Coca-Cola, or a movie popcorn. In the 1950s, a movie popcorn had 174 calories and was 3 cups. When you guys go to a movie, you take it for granted that you can order and want to order a huge bucket of popcorn, which you could easily eat 1,000 calories if you eat half that bucket holding it in your lap. Portion sizes are bigger everywhere. Now, there are varying kinds of interventions or changes we could make at individual or collective levels. How could we intervene to redress the obesity epidemic? Well, there are intrapersonal changes we could make, sort of motivational and skills interventions. Or there are interpersonal changes we could make, like targeting social norms and networks. We'll come back to social networks later in the class. So things to do with how people interact, like how they see each other. Organizational and environmental levels that we could intervene on at schools and workplaces and hospitals, or community levels like structural changes or advocacy, or policy levels like laws and regulations. And it is the case that things can change. Just look at the decline in smoking that has occurred in our society. 45% of adults were smokers in 1965 and 23% in 2001. And there's been a cultural shift in the attitudes towards smoking, where most of you guys think there's something wrong with smoking. Whereas in your parents' or grandparents' generation, smoking was seen as normal. Or look at the changes in deeply personal sexual behaviors that were prompted by the AIDS epidemic. When I was in college, getting condoms was difficult. And now you guys have condoms in every laundry room at many colleges. I don't know if at Yale that's still the case, but it is. So they're free condom dispensers in the laundry room, right? So norms have changed. Or look at drunk driving laws which seem to be working. When I was your age, and when your parents were your age, it was normal to have a drink. I don't know if you heard this expression, have one for the road. People would literally have a drink as they were leaving the party before they got in their car and drove. None of you would think that's acceptable behavior. And in fact, 30% of fatal crashes involved drunk drivers in 1982, but only 17% in 1999. So just in 20 years, smoking, drunk driving, sexual behaviors, all of these things have changed. Public attitudes have changed. And they could also change with respect to diet and exercise and obesity. In fact, many laws have been passed or are under consideration to combat the obesity epidemic by focusing on schools, including, for example, restricting access to sodas and other high-calorie, low-nutritive foods. One appropriate target is school lunches, and not just because they are so lousy. Which of you can tell me what these meals are? How many of you recognize these meals from your high school cafeteria? Raise your hands if you recognize these meals. Most of you, I would imagine. Some of you are in high school still, and you'll recognize these meals. Okay, what's the meal in the upper left?
Spaghetti.
Yeah, and those beans, were those green beans likely to be tasty or no?
No.
No. Okay, what's the meal on the upper right? Can you see what's there?
Tacos, maybe?
Yeah, tacos. There's a little chicken soup, a little tiny portion of corn, which is not the healthiest vegetable, and then a chocolate milk, it looks like. And on the lower right, what's there?
Chicken nuggets. And
Yeah,
some
chicken
type of-
nuggets. Yeah, those little smiley faces are like those chicken taters, and so on. There's a little ketchup for the vegetable in the upper left. You see that? That's your vegetable in this meal. It's counted as ketchup. Okay, but this is the school lunch in Korea. Who knows what this meal is? This is a typical Korean school lunch. Does anyone know what this is?
Tofu and fried rice and with kimchi.
Yes, and look at the healthy portion of vegetables and so on, okay? Or this is the school lunch in Greece. I can tell you what this is. Those are pomegranate seeds in the upper left on yogurt. And there's a little Greek salad of tomatoes and cucumbers and delicious dolma in the upper right. And there's some tangerines in the lower left and chicken on orzo in the bottom right. And this is Brazil. Honestly, these school lunches, these are real school lunches, people. I didn't make this up. These are not idealized. Someone took photographs of school lunches around the world. These look much better than our American school lunches, don't they? Right? So you have to ask yourself, what are we feeding kids in our society, and how is that contributing to their obesity? Structure versus agency, right? The kids in the schools don't have a lot of choice in what they're served for lunch. Now, this is an old review regarding laws in schools that gives you a sense of the variety of targets. What laws might we pass that might combat obesity by working in schools? Laws regarding physical education requirements and funding, nutrition education requirements and funding, vending machine restrictions, nutritional standards for cafeteria food, outreach to parents, or other efforts to promote a healthy school environment. And in fact, generally speaking, and we haven't discussed this yet in the course, the law can be very effective in improving public health, as we're also going to see next time when we talk about smoking. Laws have reduced our exposure to toxic lead, improved car safety and reduced motor vehicle accidents, increased vaccination rates, and reduced occupational fatalities. Legislation can save lives and improve public health. And legislative efforts have also focused on community health, not just at schools, but what can we do at the community level? We can create task forces or commissions or tax non-nutritious foods, right? We could raise the price for foods that are bad for you. We could improve the safety for walking, like adding bike trails, making the structure, making the environment more conducive to healthy behaviors. We could place restrictions on advertising of bad foods, community fitness campaigns, and so on, or insurance coverage mandates. There are lots of things we could do to change the environment to foster good health. In fact, there was a bill filed in 2008 by the Mississippi State Legislature, apparently because the legislature was motivated by its first-in-nation status, and it was, quote, an act to prohibit certain food establishments from serving food to any person who is obese based on criteria prescribed by the State Department of Public Health. Just like bars are not supposed to serve alcohol to people who are drunk, Mississippi said, well, why don't we pass laws that say we're not supposed to serve food to people who are obese? I suspect some of you think this is going too far, and you'd have to think about why. What about the soda ban initiative in New York City? There was a limit on soft drink size was to have taken place in March 2013 in New York City. The law, which was passed by 8 members of the city's health board, intended to prohibit the sale of many sweetened drinks more than 16 ounces or half a liter. And unsurprisingly, the bill was opposed by the beverage industry and was ultimately defeated in the court. So it's hard to know what to think about all these things, isn't it? Which laws would be justifiable or effective and which ones would not? Another approach, different than legislation, which I'd like to turn to, and which we'll also be discussing next Wednesday, is counter-marketing. For example, here's a billboard that you might see in a community: childhood obesity, don't take it lightly. And a kind of effort to teach the public, say, you know, let's use marketing techniques like billboards and appealing, I don't know how appealing this is, but anyway, appealing images to persuade people to pay attention. But the problem is that they are just a drop in the bucket. You know, right below this is, you know, my kind of shopping spree at McDonald's. So it's like we're spitting in the wind sometimes when we're trying to work against the massive marketing campaigns that are present in our society, encouraging all kinds of poor health behaviors. Nevertheless, though, counter-marketing can be very effective. So Counter-marketing attempts to use humor and images in inventive ways to capture public attention, galvanize public interest, and fix ideas in people's minds. So, of course, this is a play on the very famous, very attractive sculpture of David, here shown in this way, with a caption underneath saying, "If you don't move, you get fat." Or here's another counter-marketing campaign. What is this? What are they marketing here? Can anyone tell?
Is that a condom in the corner?
Yes, they're they're marketing condoms. The guy in the middle is obviously not wearing a condom. And we're going to consider counter-marketing in greater detail next time as it applies to smoking, but I wanted to give you some initial examples. And, you know, the point of this ad is to get your attention, right? It's a kind of, I won't say jarring, but it's a kind of unexpected image. So I'd like to just show you today a couple of short videos on non-health related topics that illustrate counter-marketing. So I'm going to show you one video now. I hope you can hear it. Dorothy, will you let me know if you can hear it, please?
Okay, yes. Yes, we can hear it normally.
Another place, no repercussions, but our mistakes. Rules are there for us to break. We're gonna slip through a crack in the wall, by the code, and the open scroll. It's a sunset in the ocean. It's kind of shit that keeps getting slow motion. What are you doing?
Okay. What was this a counter-marketing about? What was the public health message of this ad? This is not a trick question. I want to see some people speaking up now.
Was it about literacy and staying in school so you know how to read signs?
Yes, it's about staying in school in general, and part of it is literacy. That's right. Now, do you think this was effective, and why or why not? Come on, guys, speak up. This is not rocket science. You're all Yale students. Yes, advice.
I wouldn't say it particularly is. Like, I understand sort of what they were going for with the whole violence aspect of it and deterring kids, but I think it's it's so over the top that I don't think it really hits the message.
Yes, I thank you for that. I'm inclined to agree with you. Other thoughts? Who agrees with that bite? That this was over the top and not particularly effective as a counter? Yeah, Rena and Danielle, speak up. What are your thoughts on this ad?
Yeah, I agree. I think that I laughed at it as opposed to getting scared to stay in school.
You laughed at it. Okay. Danielle?
I think I'm left thinking about like how gruesome it was rather than like the literacy piece. Like I think that it was the main message.
So it was too much, right? It kind of distracted you, and the violence it just was so over the top. Yeah, Justin.
Yeah, I feel like the kind of student who's likely to ditch school is not really going to take the advertisement with any kind of seriousness if they can't even take schooling seriously.
Or is unlikely to have that much fun by skipping school. Honestly, we've all skipped school, but I've never had that much fun when I skipped school. So it's very unrealistic in multiple ways. And I think if you ever get into the business of designing counter marketing, one of the key axes is humor versus fear, and does fear work, and how much fear, and also is there a plausible connection between what you're seeing and what the argument is. And I think this connection here was very tangential between the images and stay in school, right? Like, you guys are probably wondering, where is this going? And then the explosions are happening. You're like, what the hell is this about? And then it's like, stay in school, and you're like, wow, that's really not the message I was expecting. On the other hand, I suspect all of you will remember this. So I've been teaching this class for 20 years, public health. I mean, I change the class every year. I change the readings, I update them, and so on. And I get emails from students for years afterwards. I can't tell you how many students write to me and say, I still remember that video of the beachgoers that were being blown to bits. So from that point of view, it's memorable, even if it's not necessarily making the connection. Okay, here's another counter marketing video. Some of you may already have seen this one.
Set fire to your hair, poke a stick at a grizzly, eat medicine that's out of date, use your private parts as piranha bait. Dumb ways to die, so many dumb ways to die. Dumb ways to die, so many dumb ways to die. Get your nose out with a fork, do your own electrical work. Teach yourself how to fly, eat a 2-week-old unrefrigerated pie. Dumb ways to die, so many dumb ways to die. Dumb ways to die, so many dumb ways to die. Invite a psycho killer inside, scratch a drug dealer's brand new ride. Take your helmet off in outer space, use a clothes dryer as a hiding place. Dumb ways to die, so many dumb ways to die. Dumb ways to die, so many dumb ways to die. Keep a rattlesnake as a pet, sell both your kidneys on the internet. Eat a chew of super glue. I wonder, what's this red button do? Dumb ways to die, so many dumb ways to die. Dumb ways to die, so many dumb ways to die. Dress up like a moose during hunting season. Disturb a nest of wasps for no good reason. Stand on the edge of the train station platform. Drive around the blue gates at a level crossing. Run across the tracks between the platforms. They may not rhyme, but they quite also be. Don't let the waves to die. Don't let the waves to die. Don't let the waves to die. So many dumb ways to die. Be safe around trains. A message from Metro.
Okay, this is a very, very famous counter marketing ad. How many of you had seen this before? Many of you. Okay. When I first started showing this ad, it hadn't been seen by very many, but most of you guys have seen it, which I think is really telling. This was made in Australia, actually, I think in Melbourne. in order to reduce deaths of people that were doing all those things, standing too near the edge of the tracks, running across the tracks, and so on. And how many people think this was effective? Okay, who thinks it was not effective? Sarah, you think it was not effective?
No, because as I was like watching the video, I felt like they gave the message like more around the end. Like I feel like they kind of beat the message like around the bush, sort of like it wasn't like they gave like other examples, so it was also kind of confusing as like what they were trying to say until you realized at the end, and the whole ad just like didn't make sense with like the trains in it.
Okay, so Sarah thought it was too long of a buildup, maybe a bit shorter, fewer dumb ways to die, and then add the train ones at the end maybe, or intersperse them. Other thoughts? Yeah, Liz.
I feel like as a part of a wider campaign, it would be more effective because you get used to seeing these images around. And so you have that jingle stuck in your head. And every time you see one of these images, whether it's around a train station or something, you would be reminded of it.
Yeah, I think that's very important what you're saying. These counter marketing campaigns are holistic, right? They're not like a single product. They are part of a bigger package. Maybe some of you have been involved in some public health campaigns before on campus, for instance, or lots of health related issues that some of you are motivated to address on campus. Suicidal ideation, sexual safety, substance use, and so on. And there are ways to like reach your audience where they are as part of a bigger package. Sophia, you had something to say.
Yeah, I was gonna say I didn't find it very compelling. If anything, I know some of those were like outlandish, but I feel like it gave a lot of ideas as to what you could do
Do you think people will actually go and keep a pet rattlesnake or get in a dishwasher or in a clothes washer?
And that's what I'm saying. Maybe that's a bit outlandish, but I think it was counterproductive to continue to give examples when, yeah, I think it was a little bit
over the top.
Yeah.
Okay.
And also even the tone of the music, like very catchy, but it almost feels like it's friendly. The tone of it, I know it's supposed to be humorous, but it's like I would argue it feels overtly friendly, as though it's like a casual notion.
Okay, you guys are really down on this, which is incredible to me because first of all, you had all seen it, and it's one of the most famous counter marketing things ever done. And yet, here we are thinking maybe it wasn't so good. There's too many ways to die. It might give people ideas. It took too long. I don't really understand it. But all of you are going to be singing "Dumb Ways to Die." I guarantee you for the rest of the day. Natalie.
Wait, yeah, I was gonna like defend it because
okay.
I feel like yeah, I definitely remember like being a kid and just like singing the song around like with my friends. And also I remember it kind of came with the game. And
really? I didn't know that.
The game being really effective. It was like you had a time limit and you had to move the people like away from the platform and stuff like that. And so I think the fact that it was able to engage all these different audiences, like all these kids about like safety, I don't know. I think it did a really good job in doing that.
Okay, that game, I did not know about that. Natalie, if you do a little Googling and find anything about that and send it to me, I would really appreciate it because I'll add that to the class next year.
Yeah, sure.
But it goes back to the point that I think Sophia or someone else was making about it has to be part of a broader campaign. And I didn't know that, and they did that. Okay, Kara.
Yeah, I was also going to talk about the game because like I remember that game being like one of my most played games as like a kid. Like I would be so addicted to that game and like the song and everything. And I felt like there's not really a shock value. Like it's more like kind of taking the like little cute characters and being able to like I guess like think that they're cute and find like a quirkiness in them that kind of makes it more memorable and something less like of a shock value that you'd like want to just like be like, oh, this doesn't make sense. I think it appeals to audiences, and I think like that's what, and it's like very like the song itself is so easy to get into your head, which is what made me like really take this and insert it in my head for like a long period of time.
Okay, so now that you told me this, that two of you have seen this game, if one of you wants to look on Etsy or eBay and find, I would love to purchase one of these for my personal collection of items, you know, public health items. I won't bore you with why I have this obsession, but I'm fascinated. I've been teaching this for ever since this ad was first released. Actually, the first few years I taught the ad, nobody had seen it. And it was a big surprise. And now, like so many of you have seen it. Advice, and I never knew about the game till today. Advice.
Yeah, I mean, I think just the value of the campaign is how recognizable it is. I think everybody here has seen it, and just the fact that I hear this sound a lot too on other different social media. There's like an association with it that you can make with the trains too, especially if you've seen the whole thing. So just that whole jingle and the fact that it's so memorable, I think that definitely helped push its message because there's always going to be that association with this campaign. And I think also just kind of obviously it's insulting people by saying these are dumb ways you could die, and that by doing this stuff around trains, you're dumb. So I think that part of it also helps push it. So I think it is pretty effective, and the game just helps add to that.
So raise your hands if you had not seen this before. Had anyone not seen this before? Sophia, anyone else? Just one of you? Only one person had not seen this before. That's amazing to me. All right, any final comments before I let you go? All right, I'm sorry again that I couldn't be there today. I'll spare you my clinical details, and I will see you next Wednesday. We'll talk about smoking, and then the following time we'll talk about drugs and alcohol and tobacco. See you next week.
Thank you so much.
You're welcome.
Thank you.
Thank you. Get well
Thank
soon.
you. Have a good night.